Yakov. I myself, Jadon Kadishta Darwanshi, working as an assistant professor in the discipline, want to from the Faculty of Physiotherapy and Diagnostics. I am working in Jyoti Vidyapeeth Women's University. It is the first state women's university in Rajasthan. Today we will discuss the topic of IOP. What is IOP? IOP is the intra-IOP, the expansion of IOP, the intraocular pressure. Intraocular pressure. What is intraocular pressure? The pressure exerted by the ocular contents the pressure exerted by the ocular contents is known as the intraocular pressure. Its normal range is 10 to 21 mmHg, but it's always about around the 15 mmHg. But sometimes it fluctuates also. How its protection in our eye, how it produces in our eye. Aqueous production by the ciliary processes into the posterior chamber, then flows it. Firstly, the aqueous protection is formed by the ciliary processes into the posterior chamber. Then it's flow to the anterior chamber and vitreal chamber. Then bulk of fluid flows out of the angle of anterior chamber. Then bulk of fluid means more amount of fluid is transmitted flows. Then what is the resistance protection? Resistance to flow at the lens iris interface. Resistance to flow at the angle of anterior chamber. Pressure in the eye increases until the force pushing fluid out of the eye results in the same amount of fluid leaving the eye as is produced and enter the eye. Aqueous exchanged with the retina, lens, ciliary body, iris and cornea. Okay. Then what will happen? Influence. What is the importance of IOP? And in long term, it may be related to genetics. Relatives of the individual with open angle glaucoma are more likely to have the high IOP. If the patient is having open angle glaucoma in its relatives, then the patient may be having the high IOP. Age also matters. IOP increases with increasing age, and IOP is equal in the age range 20 to 40 years of age. After menopause, women have higher IOP. In Africans and Americans have higher IOP, in which is the importance of glaucoma than white. Short term for diurnal variation. For diurnal variations, we 3 to 6 mmHg change in 24 hours of period and more than 10 mmHg change in pathogenic. Change probably related to aqueous production and not drainage. Then what is the how we will just like the factors are just like age, sex and sitting also. Going from a sitting to a lying position result in increase in IOP, which is even greater in glaucoma patients. Total body inversion causes an increase in IOP by as such as 15 mmHg. Okay. Now we will say if more blinking, then IOP may be raised. Exercises may decrease the IOP. Blepharospasm increases the IOP. Coughing, blood pressure also increases the IOP. General anesthesia decreases, and alcohol also decreases the IOP. If anyone is a tobacco chewer, then his or her IOP may be increased. He or may have the increased IOP. Cholinergic stimulating agents decrease IOP by increasing the aqueous outflow, and adrenergic stimulating agents maybe can lower the IOP by enhancing aqueous outflow. Okay, so tobacco chewers have increased the IOP, alcohol drinkers have decreased IOP, and general anesthesia have decreased the IOP. General anesthesia may have decreased the IOP. Blinking it increases the IOP, exercise decreases the IOP, blepharospasm increases the IOP, and coughing also. Then adrenergic blocking agents, timolol, betazolol can decrease IOP by decreasing aqueous production. Cholinergic drugs can increase or decrease the aqueous outflow, by which it decreases the IOP. Cholinergic stimulating agents are pilocarpine, ecothipate, thiopate, and adrenergic stimulating agents are propene, iopidine, epiferine. These all can lower the IOP by enhancing the outflow of the aqueous humor. Adrenergic blocking agents are timolol, betazolol. These all can decrease the IOP by decreasing the aqueous production. How the IOP can be decreased or increased? If anybody is having the increased IOP, then how you can decrease the IOP? By reducing the aqueous production or by increasing the aqueous outflow. So some drugs are used for decrease aqueous production, and some drugs are used for increase aqueous outflow. Carbonic anhydrase inhibitors decrease aqueous production, and prostaglandins increase uveous spiral outflow. Then IOP cannulate the anterior chamber and directly measure the pressure. Cannot be done on humans. The original method used to measure IOP is the tonometry. How tonometry is done, and what are the types of processes in tonometry? Tonometry, first one is the indentation. The older of the two methods to measure IOP in human being. This is the older method in which by which IOP is measured in human. Involves measuring the indentation of the cornea resulting from a given weight. Involves measuring the indentation of the cornea resulting from a given weight. Okay. Then the Schwartz tonometer is an indentation tonometer. The weight of the tonometer displaces fluid in the eyes and thus affects the IOP measurement. The second one is the applanation. It is the only flattens a small portion of the cornea and does not display a large amount of aqueous. Better accuracy than indentation. The NCT and the Goldman tonometers are the examples of applanation tonometry. tonometer plugger of a known weight pushes on the cornea. Thus, results depend on the ocular rigidity. How much is your cornea rigid? The pressure depends on that rigidity. Then, what are the advantages of short tonometry? Small and easily transported, inexpensive, does not require electricity. And disadvantages are in this the reading is not approximate or accurate. It depends upon the instrument and the position of the patient, and it requires anesthesia also for most patients. Technique can produce aberrations and best if the patient is in the supine position. Placing the tonometer on the eye changes the IOP. Goldman tonometer, the most accurate method for IOP measurement, rating between 1 to 2 mm of actual IOP flattens a small portion of the IOP. Then we will read about the theory. The cornea is covered with the tear layer which exerts a surface tension, and a probe applied to the cornea is placed against a force pushing out of the cornea. This one is the cornea. What its function? It gives shape to the eye also, and it is having some shape due to the aqueous humor inside it. So if we push something from outside or over the cornea, then obviously the opposite force will also exerted by the cornea. Okay. If the area of the probe is of the proper size, then the force from the surface tension will cancel the bending force, and this leaves pressure is equal to force upon area. The area of the probe has a diameter of 3.06 mm. This is the diameter of the probe. And what is the procedure of doing IOP? Instill the Goldman IOP. Application IOP procedure. Instill the fluorescent into the tear layer. View fluorescent pattern in the blue light on slit lamp. Doubling prism is placed on the slit lamp to view the half image of the split circle must be lined up. Pressure is equal to the number of drum times 10 in mmHg. Sources of error: improper width or position of Myers, inappropriate fluorescent levels, unusual corneal thickness. Then the advantage of Goldman tonometry is highly accurate, oldest, easy to perform, accept IOP measurement, accept norms for IOP measurement, and do not have any expenses. Now, what is the disadvantage? Disadvantage is that it requires the anesthesia. It is not a portable tonometer, and it can result in an aberration. Must sterilize instrument after every use. Now, this one is the non-contact. Non-contact means the NCT. Okay. Then, what is NCT? Non-contact tonometer achieves corneal flattening by an jet, and it looks like like patient is sitting in front of the NCT machine and put his head on the headrest and put his or her eye in front of that air jet, and the dimensions of the air jet, the pressure is calculated. Then the higher the IOP, the longer it takes to flatten the cornea. Then what are the advantages of NCT? That no anesthesia is required, not so expensive, can be portable and easy to perform, and does not touch the eye. It is a sanitized procedure. Disadvantage is somewhat expensive, not accurate at high pressure. Patient may exert more pressure in raising the temperature. That's all for today's. We will be continue this topic in our next lecture. So up to that, have a nice day. All the best. If you are having any query, then comment in comment box. Thank you so much. खुश रहिए आप लोग.